Hello, my name is Joel Barthelemy, founder and managing director of GlobalMed. And depending on where in the world you are watching our live program, good morning, good afternoon, or even good evening. As part of our ongoing series of educational events, I want to welcome you to the program today, where we are talking about the transformation of healthcare payer models, specifically looking at federal and state reimbursement. Today, hundreds of viewers are tuning into this event live to learn about how our federal and state governments are working together alongside educational institutions, private providers, and corporate entities. We want to drive better access to care while lowering overall costs. GlobalMed deeply shares this mission, and as a leading provider of healthcare technology solutions, believes in bringing you knowledgeable thought leadership who understand the issues and can provide insight. So please enjoy today's topic on federal and state telehealth policy and reimbursement. You also may be watching this event recorded, so please feel free to contact us to cover anything we may have missed. Let's begin by meeting our moderator and host of the event, Mr. Roger Downey, GlobalMed's video programming and educational content manager. Roger?
Thanks, Joel. You know, we're glad that you could join us today as well. This program is coming to you from the GlobalMed headquarters in Scottsdale, Arizona. Our video production studio is a great venue for things like this, and one that we're going to use for future programs that will be of interest to the healthcare community. Now, judging from the response that we've received, there are a lot of questions about reimbursements, and many of you have submitted questions when you registered. We're going to try to answer as many as we can during this program, but if we don't get to your question, we will post both all of the questions and the answers in the next day or two on the GlobalMed website, which is www.globalmed.com. That's how you got here. And if you registered, we'll even email you when they're up. So if you don't hear the answer to your question, please, it's because we ran short of time. But, you know, let's get started. We're very fortunate today to have Mario Gutierrez in studio. Mario is the executive director for the Center for Connected Health Policy, and that center is based in Sacramento, right?
That's correct. We're in Sacramento, but we are a national policy center.
Now, there are things that obviously we need to get squared away before we start, and these are some of the legal aspects that some people are concerned about. So why don't you explain first of all?
Well, just very simply, what we're doing today is providing information. None of this should be construed as legal information. You should always consult your legal counsel. And we're not endorsing any product or any services that you may see in our presentation today. We're advocates for telehealth in the broad sense.
And it's great that we're going to have this presentation, because this is one of those issues that, you know, as expressed by the number of questions that we have, there's a lot of misinformation, there's a lot of confusion in healthcare, even among the healthcare professionals.
That's very true. Healthcare professionals, consumers, payers, there's just quite a bit of, if not misunderstanding, ambiguity about what telehealth is and how it can be done.
Well, tell us about the center. What is the center all about?
Well, the Center for Connected Health Policy was created in 2009, and we received a grant from the California Healthcare Foundation. In their wisdom, they saw telehealth as being an important part of healthcare moving into the future. And so our primary task is to identify barriers and develop solutions. We do analysis, policy briefs, and last year we applied for and received a federal grant from the Office of the Advancements of Telehealth under HIPAA to become the National Telehealth Policy Resource Center. Under that grant, we have two primary purposes. One is to provide direct consultation and support to 12 telehealth resource centers throughout the country that are available for free of charge to provide support for those organizations that want to start a telehealth program. And we provide them with consultation on policy issues specifically. And we're, in essence, a national center of excellence on policy for telehealth.
You know, a lot of people who are joining this probably understand telemedicine and telehealth, but then we have a few people who probably are not that well versed on it. So I guess we should begin with some basics, right?
Right. So, as you say, today's agenda, what I hope to cover is an overview of federal policy, Medicare, Medicaid being the two major sources of funding for, and that provide the guidelines and framework for telehealth around the country. And we'll talk about other issues that have legal and regulatory implications for telehealth, and then where the country seems to be going in terms of future legislation. And healthcare reform, of course, has a big impact on this.
Yes, it is. Again, that's healthcare reform as somewhat the problem and the solution, in a sense. You know.
That's right. That's right.
Go ahead.
Well, shall we get into it?
Sure.
Good.
Let's go.
All right.
Let's go for it.
So, as you said, what about telehealth? We are at the center receiving more and more questions about what it is, how do we get reimbursed, who can do it. But basically, we need to start from the public policy point of view. What is legal in terms of of your particular state? What's allowable, I should say? And what are the considerations that should be taken into account as you start and get into a telehealth program. And as you can see from the questions that we received today, wow. There's a lot of ambiguity, a lot of concerns, and I think a lot of interest. That's the main thing, is there's a lot of enthusiasm for telehealth, but my goal today is at least to provide some context for the policy areas that need to be considered. So getting right into it, one of the first things I like to do is set a context for a definition of telehealth. I'm not using the old term telemedicine, chiefly because telehealth now encompasses a broad range of services from dental care to behavioral health, even genetic counseling. We're seeing all kinds of applications. So quite simply, telehealth is the use of telecommunications, health information, video conferencing technologies to deliver medical care, health education, and other health services. It is technology-enabled healthcare. It's not a separate service, it's a modality for delivering health.
Okay.
There are three components that we generally look at in terms of the policy areas of telehealth. Live video is the most commonly known in terms of the services in which it's done in real time, consultation between a provider and a specialist, for example, or for language translation from multiple language folks. Storeandforward is a newer form of telehealth, but I think one that increases the efficiency and quality of care, where technologies are transmitted with patient information from a primary care physician through clips and videos. And thirdly, remote patient monitoring, which is anywhere a person may be, whether it's in their home, in a school, in a prison, whatever the setting may be, to be able to monitor healthcare in a way that provides real-time or Storeandforward information on health.
In the event people aren't watching this full screen on their monitors, on their computer, and are seeing very small imagery, we'll have these PowerPoint slides up on the internet so that you can see all of the information that is on these slides. Sometimes it's difficult to read in the smaller format.
Sure, great. Just some examples of the different kinds of telehealth applications. Here you have two examples. The more routine, in the top two pictures you see a medical specialist providing consultation to a primary care provider or a nurse with a patient. And so that patient feels like they're in the room with that specialist. And it is it's virtual and allows you to have that conversation. Prevents that patient from having to travel long distances. It also enhances the ability of that primary care provider to be able to have the confidence in the treatment of that patient, knowing that they have the support and assistance of a specialist. Another very different form of live technology, as you see here in the second two slides, is in an emergent situation. Here you have a pediatric intensivist in a medical center, this happens to be in Sacramento, providing consultation to a small hospital hundreds of miles away for a child that's been injured in an accident, and be able to provide that same care as if he was standing right next to that patient and that nurse.
Yep.
And telehealth technologies related to Storeandforward, this is actually one of the areas that we think has great applicability now as we're moving more into expansion of healthcare, where specialists, particularly dermatology, ophthalmology, pathology, and long-term radiology has been using this for a long time, in which video clips, digital information is sent securely over the internet, and that specialist in their own time can review those and determine whether or not there is a need for personal consultation. So again, it prevents the patient having to travel long distances for a consultation or for follow-up.
And I was just in Salt Lake City last week for this National Genetic Alliance conference, And even the imagery that they develop for family pedigrees and for just genetic counseling, they could easily be saved as well, stored and forward.
Exactly, and I think it's a great benefit, particularly for small rural communities, so people don't have to travel. The third and probably the fastest growing areas, as I mentioned, is remote patient monitoring. It could be in the hospital, it could be in the intensive care unit, at-home management. We've seen great success, for example, with what's called Tele ICU, in which patients who happen to be requiring intensive care in a smaller rural, or it can be even an urban isolated area with limited technology or access to an intensivist, can receive 24-hour care through monitoring as well as direct consultation with the intensivist at long distance. And in a command center at that hospital, they can monitor 4 to 5 different hospitals at one time. So it does save money and save lives.
Yep.
So let's just get into the policy issues.
Well, this is where we start to meet
right.
where the rubber meets the road.
Exactly. So the most important national policy issue, of course, is Medicare. It's been the longest-standing national program in terms of the provision of services for the aged and for the disabled. Unfortunately, the laws and regulations under Medicare have not kept up with the rapid advances of the technology and its utilization. So we're still living in a mindset of just live video is all that gets reimbursed in the telehealth, with a very narrow definition of where that patient happens to be, in a definition of rural that really eliminates large swaths of the country. For example, California, a rural state, but according to this definition, over 90% of the state does not qualify for Medicare reimbursement.
And the hard part of that is just deciding if you're in a rural area sometimes, because they're so vague as far as the guidelines are concerned.
Right. So there is on the website, Medicare, you can actually put in your address to see whether or not you qualify or not. We're hoping that this is going to change in the next few years because it's absolutely necessary, and we'll get into more of that as we go along here.
And it will also encourage doctors to use telemedicine in urban settings. That's really the problem, that we can't use it in urban settings and doctors can't get reimbursed.
Well, exactly. The other aspects of Medicare which I think are a problem is that, again, very traditional sites, physician, hospital, federally qualified health center, not the broad range of potential benefits of telehealth that could be applied. Also, who can do telehealth? Very limited to physicians, nurse practitioners, PAs, and other specialists in clinical social work. They're a very narrow list. What's reimbursable? Essentially, there are 15 codes that specifically state what service can be reimbursed, and very narrow: teleconsultations for emergencies or follow-up for inpatient. If you happen to do subsequent care in a hospital, it can only be done once every 3 days. If it's in a SNF or a long-term care facility, once every 30 days. So it's counterproductive to where we're headed in healthcare.
Wasn't there concern that when they initially passed this legislation in 2001 that telehealth would be overused? Exactly,
and I think that's one of the biggest misconceptions of telehealth, is that it's going to add tremendous cost to the system. Well, in fact, what we have discovered is that it's had the opposite effect. That the billings, because of these restrictions, to a large part, are limited considerably to the estimates of whatever it was going to be, 150 million a year or something. Well, in fact, it's not. That has not been the case, either at the federal level or at the state level.
Yeah, I think so. And let me ask this question rhetorically. Can you think of another program in which the government has overestimated the cost?
I think this is the only one where I've seen such a dramatic estimate.
I know.
Right, it just doesn't make any sense.
Yeah.
So, and the federal policy makers are looking at this, Congress is looking at this, and I think as we get into the presentation, I'll talk about some of the new legislation that hopefully can solve this as we move along.
Good.
Okay, so the real action is at the state level. We, under the CMS rules at the federal level, every state has the ability to determine their own policies and set up their own programs in terms of their Medicaid program, both in terms of legislation and regulation, as well as their administrative guidelines for this. So what do we have? We have 50 states with 50 different approaches to telehealth. One of the first things that we did at the center when we received the federal grant, our staff, Mei Kwong and Christine Caloro, our researchers on policy, spent 6 months going through every single state's policies, combing through every Medicaid manual, looking at Nexus Lexis to determine what the laws and pending laws are. And what we have for the first time, I think, is a comprehensive, real-time source of information on every single state. If you go to our website, which we'll talk about in a bit, you can click on any state and it'll tell you just what the current laws and regulations are, and also allow you to hyperlink to their particular source that we used, so that you can get the particular codes and have all the information necessary as to what the state of reimbursement, who can do it, under what conditions, et cetera.
And you put this information into regular layman's terminology. I mean, you don't have to be an attorney to understand this, right?
Right. This is done in a way that it's just enough information for people to clearly understand correctly, because a lot of this is technical, but we've put it into a way that we hope is usable. And we're monitoring it on a very frequent basis, because laws are changing, very rapidly.
And you got to keep track.
Exactly. So we also looked at 11 very specific areas of interest from the questions that we've gotten at the center. So it's not just how to define telehealth, but very specifically under what conditions, who can do it, whether they have, for example, informed consent regulations, what other aspects of this. So you'll see on the site that you can also search by a particular topic. So if you want to see of all the states in the country that are reimbursing for Storeandforward, for example, you can search under that regard. So we're making it as usable as possible to advance telehealth in the way that we think is necessary.
Okay.
So here's the good news. The good news is
I like this slide. He's going to explain this, why this is so significant. I like this slide. There's one state there that just sticks out like a sore thumb.
They do things their own way in Iowa. And even though there were some of the early pilot programs in the country, we could not find a single piece of evidence in terms of their regulations, their Medicaid manuals, or in law that provided any kind of context for the use of telehealth. And then you have those crusty New Englanders. They haven't come up with anything either. Although I will say, as a disclaimer, Massachusetts and New Jersey are Medicaid managed care states. And so under those conditions, they may already have built in the use of telehealth, but it's not in the specific fee-for-service kind of approach as you see in other states.
Okay.
So, but the good news is that every state has some form of language. Now, this should not be interpreted to mean that every state is doing, wonderful things with telehealth. It could be a very narrow thing, like in Florida, for example. The only thing that we can find in Florida was that they will reimburse for teledental services. That's it, nothing else. But they do have something in their regulations that talk about reimbursement for teledental.
The Dentists Association must have used some political capital on that.
I had no comment. We'll see where they're going with that. They're all over the map, literally and figuratively, with what they provide, but there are some common things. So we found that, not surprisingly, 44 states reimburse for live video, 10 states reimburse for remote patient monitoring, but only 7 states for Storeandforward, which is surprising, and we're hoping to see that increasing. And then there are some states that actually provide you a small amount of reimbursement for a transmission fee. The bottom line is that no 2 states are alike. And that's an area that we're concerned about. One of the things that we're doing at the Center for Connected Health Policy is developing model legislation. So we're both using the legislation that was passed in California, which is one of the most progressive, comprehensive bills that was passed just this last year, as well as the language that's being used in other states. Arizona, for example, just passed, I guess the governor just signed it yesterday?
Yes.
On requiring private payers, for example, to pay equally for a telehealth consult as they would for an in-person consult.
However, it doesn't go into effect until January 1st, 2015.
Progress.
It is progress.
It's progress. But we're looking at all those legislative languages across the country, and one of the real barriers for folks to for a state, whether you're a legislator in the state or an advocate, is, okay, we want to see better laws, but how do we begin? Well, we can provide you with model language that can just be taken and put into a bill. So I think that's one of the things that we would advocate for.
And that model language captures all the elements of telehealth or in some way?
Exactly, exactly. So if you just want to pass a bill limited to one area, you can just lift that out and use it. Or if you want a comprehensive bill like we did in California, you can use the entire language.
You know, there were several questions that we received. How do you get telehealth in our state? Or, you know, some kind of question like that. So if they have access to this suggested language, this would be something that could show a lawmaker friend or somebody that, you know, has some influence at the state capitol.
Right. And not only the lawmakers, many of these changes can happen administratively by the Director of Health Services or the Governor's Office issuing you know, their particular regulations to expand the use of telehealth.
Or if at the medical board level, even, you know, interpretation of current state law that may not even mention technology.
Exactly, exactly. So there are some interesting features that we found in terms of the types of reimbursement that's being provided. Clinical consultations, mental health, radiology. The most common obviously are physicians and nurses, but there's some unique things that we found. Some states will reimburse for home health, for dental care, as I mentioned earlier, speech and language pathology, different types of providers. For example, in Oklahoma, they allow for genetic counseling under telehealth and reimbursement under their Medicaid program.
That's very forward thinking.
So there you find some very interesting pieces in different parts of the country. So I wouldn't say there's any one state that's got it and figured out, but I think looking at all these states together will give us some commonality. And I think that's what we're looking for, is consistency in language so that we can have comprehensive understanding of what telehealth is and break down those barriers for its utilization.
So in your research, you didn't find a state that would be the model for reimbursement?
There's no, at this point, I don't think there's any particular state that's got it all figured out.
Yeah.
And I think that's because states have different motivations behind what laws get passed. What we do find is that states tend to be copycats. So they'll look at the Medicare regulations and say, well, we'll just adopt what Medicare does. Or we'll look at the state next door and say, well, they just passed this law, so we'll do the same thing. So Arizona and New Mexico have very similar kinds of laws. But what we're trying to get to is, short of what we believe is the ultimate answer, and that is that telehealth becomes the standard of care. And we no longer use the tele as a qualifier.
Right.
That is, as I said earlier, is technology-enabled healthcare. It's just another important, if not vital, tool of a healthcare provider. Radiology has done that. You don't hear teleradiology anymore.
No, you don't.
So, but it's become the standard of care. So long term, of course, we'd like to see that being part of the way care is provided. Instead of having a separate billing code in Medicare for a tele something, it should just be part of the care of delivery.
Now, the billing codes sort of treat telemedicine or telehealth as a stepchild when you come down to it, because it has a special identifier, and that's...
And that constitutes a second-class care.
Yeah.
When in fact it's enhancing and expanding the quality of care. So just moving on with what we learned from the survey, just a few other things. 8 states have, for example, geographic limitations. So they may limit it to a rural specification, like Arizona does. You have to be within outside of a 50-mile radius, or you have to, be in a certain. The patient has to be in a certain location. 9 states have SNF eligible sites. That's going to be a bigger and more important issue as we baby boomers get older, and the demand for care outside of the usual setting.
I know a lot of people know what SNF is, but
I'm sorry. So this is the long-term care facilities that usually people who are in an older state that are not hospitalized in an acute care center, but are in a long-term care facility.
Okay.
And then, interestingly enough, 23 states are silent about location. So that's could either be good or bad. Depends on who is interpreting the laws. Other findings that I think are important: 20 states have some form of informed consent about Medicare policy, Medicaid policy. We've attempted in California to remove any form of informed consent because we believe that you do that with HIPAA regulations.
Sure,
and there shouldn't be anything above and beyond that. Some states require oral consent. Some have actual written consent. One of the important things about telehealth that I think is critical is that the cross-state applications, telehealth turns the country upside down in terms of these geopolitical boundaries between states. We tend to operate as regions.
Yes.
And yet a physician who's providing care for a patient that may be 20 miles away but in a different state can't provide telehealth services. So actually 22 states have some form of language that allows for a physician or a provider to provide care under certain conditions across state lines. So that's encouraging.
It is. But hopefully we can modify that down the road, but you're going to tell us about that.
Right, right. The other thing that we're seeing a trend across the country is this movement like you had here in Arizona, where 15 states now have laws in place that allow for, or that require a private provider to reimburse equally as if that person was a live consultation. And there are 4 states that have just passed laws that have not come into effect. As you mentioned, Arizona doesn't happen until 2015. But this is an encouraging trend in that it's recognizing telehealth as being equal to a face-to-face visit.
Yes, and that's one of those things. What is face-to-face? Sometimes that's open to interpretation as well.
Exactly, and that's open to every single state. We believe, I think that the trend has been that if you're doing a live consultation, that should constitute face-to-face, because you're having a live conversation with that person you're able to observe, and with a primary care physician who happens to be in a real face-to-face situation as part of that 3-way conversation.
Okay.
Now, the other issue is in terms of how we move forward is the states have a lot of commonalities, as I mentioned earlier, and what we're hoping to do is to see that all of this becomes more uniform, as I mentioned. So the trends that we see in state policy, we see some very progressive trends in terms of private payers. Reimbursement for remote patient monitoring seems to be growing, but we also are monitoring very carefully some disturbing trends that we see in some areas in which they continue to use a very narrow definition of telehealth and creating more barriers in terms of geographic limitations. So those are the highlights of the federal and state laws that we should be aware of. And then, again, if you want more detail about your particular state, go to our website, www.telehealthpolicy.us, and you can find very detailed information about your state.
So it's www.telehealthpolicies.us?
Yeah, I'll have it on the screen here,
Okay,
so
right,
we can
right.
get it exactly right. Aside from the federal and state laws that are governed by CMS, there are a few other considerations that we should talk about. That as groups or individuals are thinking about starting a telehealth or telemedicine program, that are important to keep in mind. The Stark Law, anti-kickback, issues around licensing, credentialing and privileging, and malpractice insurance are becoming issues that need to be kept in mind. I'm not going to go into details on these, but essentially the Stark Law and the anti-kickback law have to do with financial gain in the utilization of this kind of service, where there may be some financial interest. And there are some safe harbors that are allowed under this, and you should always consult with your legal counsel as you set up your programs, but it's something that needs to be addressed. Licensing, here's a big issue, as I mentioned before. We have 50 state boards that determine licensing for not just physicians, but other professions, and issues around state licensing, and the whole notion of consumer protection comes into play here.
That's right. In fact, when you consider it, there's really 70 medical boards that license doctors, because some are joint boards that license both MDs and DOs, and then there are some boards that license, there's one for an MD and there's one for a DO, so that's why there's a discrepancy there. It's more like 70.
So I think that we can't lose sight of the fact that the medical boards play a vital role in helping to move forward progressive and common sense telehealth policy. There are some movements on the federal level to have some form of bill for national licensure, or to allow for special considerations for people who are working in federal facilities. I think that's a good trend. Certainly we always have to keep in mind the consumer protection, but something's got to give in this whole approach, because we can do things at great distances. I mean, it's kind of ironic that we can have a consultation in California from UCLA Medical Center to a small town in Modoc County, 600 miles away, but 100 miles away in Arizona on the border becomes a whole nother issue.
Right. Should we take some questions? Let's
Sure.
work in some questions here. This one says, and I think this came in on the chat aspect. If you have a question, you can send it to us via the chat. What are policies that set up safety issues for telepsychiatry? That is, having a clinician present with the patient. In other words, on one end is the psychiatrist. Who should be with the patient on the other end, or should there be anybody?
Well, again, I want to remind folks that every state has their, as long as it's Medicaid that we're talking about here, it should be according to the state licensures requirements, and certainly you want to have a psychiatrist. And what I've seen, for example, in some of the telepsychiatry consultations, where a psychiatric nurse could be answering, or a social worker could be posing questions to a patient that's being videotaped, and then that's encrypted in email, sent to the psychiatrist, so that the psychiatrist can have a determination and be able to view that patient in almost like in a real-time situation. So again, it varies from state to state.
And you know, obviously specialists are collected and gathered in urban areas. So these specialties aren't necessarily available in a rural area, and that's why a lot of times they're trying to think of ways to provide the counseling that is needed, in a sense, to help that person that doesn't live in an area where the psychiatry is available. Okay, now this one says, we talked about Iowa. This one says, I am pretty certain that Iowa Medicaid does pay for telehealth services. So what do you say to that?
Well, all I can say is that in our search, we found nothing in their regulations and in their manuals related to telemedicine, specifically stating telehealth or telemedicine. So if they do, it's part of their practice, but it's not, and certainly whoever sent in the question, if you can send to us the specific codes or regulations or even law, we'd be happy to change that. Because we do know that telehealth is occurring in Iowa. Certainly private insurers are paying for it, and there are some health systems like Avera that are very advanced in telehealth, but we couldn't find it in their documents.
Okay, well, this one comes in, is there a resource for writing policies for telepsych? We are developing this program for the ground up. And another question, what insurances are providing for reimbursement in New York? I think that's pretty too specific for us to answer. You almost have to go to your website, don't you, to find out information like that?
Well, particularly for if it's Medicaid. Now, for private insurers, we're in a state of flux now, with health exchanges being formed and private insurers changing their viewpoint on telehealth, because they see telehealth as a real contributor to not only cost savings, but increasing quality and access. So I believe that we're going to see more and more of the private sector, private insurance sector, looking to telehealth as a real answer for being able to meet the growing demand. I don't know specifically about telepsychiatry. I think the local psychiatry societies and the National Psychiatric Association, or their trade association may have more specifics on that.
When do you expect the dust to settle? In other words, we'll have a lot more answers than questions?
Well, I think over the course of the next 2 to 3 years, as we see the implementation of the healthcare reform legislation, in whatever format that finally settles into being, having a real shakedown effect into moving from a fee-for-service modality to a system that is quality-based. It's based on keeping the patient, the individuals healthier, working as a team, and so that's going to take some time. That doesn't happen overnight. Yeah. The most common terminology that's used in the industry today is disruption. Major disruption to the healthcare systems, because people are used to, particularly physicians and specialists, are used to operating in their own world. This is going to require much more of a team approach to care. And I think it's going to take 2 to 3 years at minimum to begin to see how this changes, and also how, as we see the older generation of healthcare providers retiring and new generations of trained individuals who are so used to being connected that it becomes part of their...
And we can say older because we're kind of veteran.
That's right, that's right.
Do you have information that applies to Puerto Rico?
The only thing I can say about Puerto Rico is that the Telehealth Resource Center that's based on the East Coast has responsibility for providing consultation and direct support, and I would encourage the person who's interested in that to contact her, just to go to the website and be able to contact specifically the Northeast Telehealth Resource Center. They are governed by Medicare. They receive Medicare services. I'm not sure about anything else in terms of their public dollars.
And that sort of qualifies too for Guam, for the Virgin Islands, for U.S. Virgin Islands, for the Northern Mariana Islands.
Well, we have a Telehealth Resource Center based in Hawaii, and they cover all of the territories of the Pacific Islands as well.
Don't know if we have anybody watching from Guam. I just thought I'd throw that in.
You never know.
Yeah, well, these days you don't. There are, let's see, I'm trying to read this. There's any policies to integrate with foreign policies to sell or buy health services with another country? The only thing I can think of is the Medicare rules regarding what is reimbursed in foreign countries, because that's sort of a quagmire of a little policy is in effect. If it all relates to where the health care hospital or provider is located in relation to the nearest U.S. facility. I mean, these are rules that you almost have to read to understand.
There are a few dynamics that we should keep in mind here. One is there are hundreds, if not thousands, of Americans retiring to foreign countries, Mexico, Costa Rica, et cetera. And so they carry with them their insurance. I think at some point we're going to need to look at how telehealth becomes a player on that. In the opposite direction, as we move closer toward immigration reform, and there's more of a normalization of the Mexican population that's in this country working, that their insurance in Mexico could cover for costs that they may have. And so there may be some possibilities there, so that it's not always a total dependency on the US system, that their telehealth system, particularly for things like psychiatry, where culture is such an important aspect. You can do a psychiatric consultation from Mexico to a patient that's here in the United States and not be a burden on our system. But those are things I think they're farther down the road.
Okay. And we're responding basically to questions right now that are on the chat on live stream, but we've received earlier questions from you when you first registered, so we can run through some of these. Any clear definition regarding what constitutes face-to-face? I think we sort of answered that, but again, it's really up for interpretation.
State to state. Some states require true face-to-face, and moving that direction. Other states will consider the video conference, a live video conference, to be acceptable.
And I can speak about Arizona, that what was in effect prior to the passage of the telemedicine parity bill that the governor here in Arizona signed yesterday was just the medical board interpretation that face-to-face could equate to video conferencing. Are there any recent developments regarding state licensure for physicians and registered nurses in multi-jurisdiction telehealth?
Not that I'm aware of, but it is certainly an area that from the federal level, there's great interest, I think, in looking at more of a regional approach to telehealth and working with states that have that interest. And as I mentioned earlier in our presentation, there are 22 states that allow for cross-state licensing, and so I think that's certainly a trend that we want to see and encourage.
Any pending legislation for store-and-forward reimbursement that you've detected?
There are, I believe, 20 to 23 states that have some form of new legislation pending for telehealth. Some of it includes store-and-forward. We are hopeful that with the future opportunities in reform of Medicare and the so-called doc fix, that there will be an opening for Congress to expand beyond video conferencing to include store-and-forward. That's one of the policy objectives of the American Telemedicine Association, for example. But we're hopeful that as I mentioned earlier, that we can provide that model language for states that are interested in doing that. And that's one of the things that we're concerned about, is that if we're going to be fixing and expanding telehealth legislation on a state-by-state basis, that it not be done on a piecemeal basis. So to the extent that if a state is interested in making some changes, that we look at it as comprehensively as possible so that they don't have to always go back and say, okay, we fixed Storeandforward, now what about remote patient monitoring, things like that.
Yeah, well, maybe we should explain, at least at this point, the bill that Congressman Mike Thompson from California had suggested at the very end of the last legislative session at Congress, the congressional session, that didn't really get acted upon because it came in like 2 days before the congressional session ended.
Right.
But the idea, I think, was to spark interest and perhaps find co-sponsors. So where do we stand with that? And tell us a little bit about what that bill would do.
Well, Mike Thompson has been an active supporter of telehealth going back to his days when he was a state senator in California and wrote the most progressive state law back in 1996. So I think he's continuing that interest at the congressional level. He has observed, and I'm sure that there have been advocates from ATA and other sources that have been able to convince Mike Thompson to think about this in a comprehensive way. And so what he did was to develop, I think, was a very well-written bill that covered the broad range of issues that I've covered in my presentation here, where we have gaps in federal and state guidelines from CMS. Clearly, when he introduced it in the last session, it was an opportunity to elevate those issues and to show that there's serious interest on the part of at least one congressman, if not more, to achieve changes, and to signal to the administration that there needs to be some action. We haven't seen the bill introduced yet in this new Congress. We're hopeful that at least, hopefully, parts of that could be introduced, particularly issues related to cross-state licensure. I think it's a very important area that needs to be considered. And as I mentioned before, changes in Medicare legislation, when that happens to be before Congress as well.
A lot of interesting pieces in that bill that really will change a lot of things, how we're doing them now. It's not a national telemedicine license bill. We want to make sure that everybody understands that. But what it does do is allow a doctor to be licensed somewhere, Arizona, New Mexico. If they're licensed in a state, they can do telemedicine to any state. Or they could even move to New Mexico and practice medicine. And then when their license was up, let's say in Arizona, they'd have to apply to the New Mexico board to be licensed if that was where they planned to stay. So there are a lot of things that would change.
There are solutions, and I think it's going to take the goodwill of the state medical boards and the National Medical Board Association to come to terms with what makes sense.
Okay. Who is under the gun for telemedicine, this question asks? The medical boards to accept or acknowledge the practice of telemedicine, or is it providers' acceptance to offer it?
If I had to choose who's under the gun, it would not be the medical boards. They don't have any real obligation. Providers are coming along, but they're not under the gun. It's really the policymakers. I think the general sense is that government has an obligation here to recognize that there is a tool that is being used, it's been used for over 20 years, that can help advance what's called the triple aim of healthcare reform. It improves the quality, helps achieve the outcomes that we want for individuals, and it reduce costs. We have a number of studies that we put up on our website that demonstrate that telehealth, for example, under telestroke, saves considerable dollars. And so if anybody is under the gun, it's the states and the federal government to be able to understand that this is something that needs to be advanced in a way that's intelligent, that's right, and helps to provide a real tool for the provision of comprehensive health care in the new world as it's developed. As we move more from a fee-for-service model to a value-based model, telehealth becomes absolutely vital, if not essential, for that.
Let's say even if the Affordable Care Act doesn't go through in all of its sections and everything else, we still need telehealth.
Absolutely. If anything, just to take one example, aging population, particularly in rural areas, where the goal is to monitor chronic conditions, particularly multiple chronic conditions, allowing patients to stay at home, or individuals to stay at home, not have to be institutionalized in long-term care facilities or any other kind of institution. These are technologies that are at our disposal. Remote patient monitoring is exploding with new devices and ways that people can stay at home and receive care. It is part of it should be part of the healthcare system, keeping people healthy, allowing them to stay in their own environment, and without having the ability to get reimbursed for that as part of their insurance, creates obstacles. So what's better is to have somebody sitting in an institution at great cost, or being at home with their family and being able to monitor the healthcare and take more responsibility for their own healthcare.
And it's personal responsibility has a big role in what we're going to face as our healthcare system changes.
Right, and we've seen like some of the new technologies in gaming that are being used for physical therapy, for example. Now somebody can be in their own home and be able to have a video screen and be monitored in a way that the correct motions for post-stroke care or for injury can be done without having to leave to go to a physical therapist's office, for example. There are all kinds of new things that are being developed that save money and improve the quality of care and ultimately save long-term the cost of the system.
And more convenient for the patient too. Where do I find a good resource to Medicaid reimbursement by CPT codes?
Well, the Center for Connected Health Policy is your best source, I would say. If you go to our map on our website, you will be able to click on a particular area of telehealth reimbursement, and that will have a hyperlink to the sources that we used to include that information on the website. So we may not have, we actually don't have the very detailed CPT codes, but we have the way to access that directly. Also going to accessing your regional telehealth resource center funded by HRSA and the Office of the Advancement of Telehealth. Those are also listed on our website, can be a good helping hand in understanding what's going on in your state.
Is it legal to practice telemedicine in the state where you are licensed if you are physically present in another state? So let's say the doctor is an Arizona, I'm going to use a local thing here. So the doctor is an Arizona licensed physician. He happens to be in New Mexico, but he's got a patient in Arizona who needs to see him for some reason or perhaps even get a prescription. Can he do that legally? I mean, we've talked about this off the program.
Yeah, no, it depends again on the state, but if it's across state lines, it really has to go back to what the state medical board has determined to be and what the state law is in terms of cross-state licensing. Within a state, you can have a specialist that's in an urban area be able to provide services to a client that's in a rural area for Medicare, for example, if that client happens to meet the requirements of the law for Medicare. But across state lines, it's really highly unlikely. But some states do allow for something like that.
A reminder, we're going off of questions that you have submitted perhaps while you were registering or just thinking about joining us today, but if you still want to try to get a chat question in, we'll try to get to that as well. The ones we don't get to during the program, though, we will post the answers and the questions on our website in like a frequently asked question kind of format so that we don't leave you high and dry on your particular question. Can you describe, this one's going to the business model now. Can you describe the capital investment implications, that is, how much does it generally cost for a provider to establish telehealth capabilities, and does Medicare, Medicaid provide grant funding, or are there any grant sources available? This sort of suggests that somebody is just now thinking about getting into some sort of telehealth part of the practice, and they're trying to figure out how we get paid.
Oh, those are fundamental questions. They're outside the realm of what we do in terms of the policy limitations. But things to keep in mind is not just the technology. It's, when it comes to the technology is finding the appropriate technology. A lot of times people overbuy or convinced that they need the Cadillac system when they don't really need that kind of system. The systems are changing rapidly. I think you really should consult with experts in the field as to what's appropriate and be able to, like any consumer, do some comparative shopping. But what doesn't get considered a lot of times in the business case are the related costs of this disruption that I mentioned earlier. When you move into a telehealth environment, you really need to think the entire practice from top to bottom. Having a telehealth coordinator is essential. Having people on staff who understand the technology if something goes wrong. Changing the patient flow, for example, so that the physician or the provider it's built into their schedule that they're having a consultation as opposed to being pulled out of an office. These are things that we've learned through our programs and our initiatives. So there are those real costs in terms of personnel that need to be considered. And then there's the cost of connectivity. The FCC has provided millions and millions of dollars across the country so that high-speed broadband is available to at least 90% of the country, I believe. That's available through, in California, for example, we have the California Telehealth Network that subsidizes that care. And if you're in an area and you don't have broadband on your system and there is a provider, you should contact your local provider of FCC-funded telehealth or broadband access, because it can be subsidized. So these are all the things that need to be considered in the business case per se.
And there's a concern about the established staff that you have, how the dynamics of moving into a telemedicine or telehealth part of the practice will affect them, and will they be interested in it? Will they look at it as something, they don't want to be involved in? You always have to have champions.
You have to have champions, and it really boils down to the willingness of the providers and the staff to do that.
Well, let's see if we can get a couple of more questions in. We're running short on time pretty much now. If we are using telehealth as a value-added service to our clients and do not expect to be reimbursed by Medicare or Medicaid, are there concerns about following certain regulations, that is, HIPAA or consumer?
Well, absolutely. It's just, the concept message here is healthcare is healthcare is healthcare, whether it's done in person or whether it's done virtually. And whatever rules apply under HIPAA apply similarly to any situation in which you're providing it virtually through video conferencing. So absolutely, whatever, whether it's liability, medical liability, or HIPAA, or other concerns that guide the provision of healthcare need to be followed the same way.
Personal healthcare is personal healthcare information. To whom and through would I have to be to contact to include Puerto Rico in this new federal law the bill that's currently being thought about by Mike Thompson? I would imagine you have to contact Mike Thompson.
I would suggest that would be the first place to start, and through your representatives in Congress.
And again, he's the congressman in California.
He represents a large swath of Northern California.
All right. And it's Michael Thompson. We are planning to provide telemedicine services to other providers and other practices in the community and linking them to various psychiatrists who set up to provide psychiatry. Therefore, we will be providing value-added services that are logistically and practically difficult due to the commitment of time and makes this service difficult to sustain. I don't know where they're going with that, but I guess they're describing their situation. Any thoughts on that?
Well, I think what I would advise is to look at the various forms of telehealth. We have observed and have been impressed with the ability to do this on a store-and-forward basis, where you can increase the efficiency of the use of telepsychiatry. Now, as we've discussed, that eats up a lot of that broadband, so transferring that information in any kind of encrypted email is difficult and not impossible. So there are some technical issues that need to be overcome, but when it comes to telepsychiatry, I think that's one of the newer areas that are being developed, that it doesn't necessarily have to be in real time.
How do you perform a physical exam for telemedicine? You want to take a stab at that, or you want me to try?
I've never done a physical exam.
Well, obviously, you have to have the video component, okay? Yeah. Now, a lot of people think all you need is the video conferencing camera. Well, it depends. Can the video conferencing camera that you're using for communicating with a physician or the healthcare provider at the remote location, is that good enough to look at a skin lesion or a dermatological problem? Or, it's hard to hold your mouth open and see down your throat unless you have an exam camera.
I want to be serious about this question because I think it's getting at a more fundamental issue, and that is that there's concern that with telehealth, telemedicine, that you lose the touch factor.
Right.
We always expect that in a healthcare system, particularly a team approach of a medical home, that there's always going to be a primary care provider that is conducting that initial physical examination. It's not replacing medical care, it's enhancing. So for example, as the example that you brought up, a primary care provider could very easily do a physical examination, and in the course of the examination see a suspicious lesion. Well, he or she has determined that that's something of concern through touch.
Right.
But the consultation doesn't have to be by touch. High resolution picture sent to a dermatologist at a different site can make that determination quite easily.
Also, in those kinds of situations, we use patient presenters anyhow. These are lower level providers who act as the hands and experienced people who know how to follow directions from the physician. So if the physician says, touch this and tell me what it feels like, they have an idea of what he needs to know or wants to know.
Absolutely.
So those are the things too, so that would help you. We have maybe time for a couple of more questions. For services like remote cardiac monitoring that may not typically require the physician to be in person with the patient, are these services considered telehealth for reimbursement services?
They're within the framework of telehealth. What we've seen in the skilled nursing facilities, the SNFs as I called them earlier, is that you can very easily monitor through the new technologies that are available, so that that's actually a big concern now with under the new health reform laws that require or that penalize hospitals for readmissions within 30 days. Within a skilled nursing facility, that patient that has a heart problem can be monitored very effectively.
Okay. Let's see, we have other questions here. Do you in the future see a need to make telehealth service mandatory among the other normal health services provided by physicians, clinics, and hospitals?
Boy, that's a hard question to answer. I don't see, I think it's not that government is going to mandate. I think the consumer is going to be the driver here. That the ability for people to receive equal care, it's the great equalizer in my mind. Wherever you are, whether you're underserved, on Medicaid, or have the best insurance in the world, telehealth provides the great equalizer to be able to have access to the best quality of services, everything from primary specialty care to post-care to home care. And so I think the consumer is going to be one of the bigger drivers here that's going to require systems to change and for payers to change. There's going to be a real demand for it.
And we have so many areas in the country, small counties generally. I mean, out here in the West, we're used to very large counties, but in the Midwest and in other areas, the counties are small and they have very little, they have no hospitals there.
Right.
They have no real serious healthcare situations where they can go. They have to travel. So this is going to be something that will benefit them when we can get that going and encourage telemedicine to take part.
Technology is a big part of our lives. We think back 10 years where technology was and what our phones look like and what our TVs look like. Things are changing dramatically. Physicians and other providers are being trained with personal devices and access to technology for information, for any number of things. And the consumer is used to technology. It used to be the fact that somebody was on a video screen was kind of disconcerting. Now it's just way of life. It's people do this. They Skype with their grandchildren. So why shouldn't they Skype with their doctor?
Exactly.
Not Skype, but
And as we do see some of the turnover in the older generation of physicians to the younger generation, those people have been using iPads and iPhones since they were walking almost.
Oh yeah, and in fact there are some medical training programs like University of California, Davis that I'm familiar with that have a special training program in rural healthcare in which this is part and parcel of what they learn. It's essential to their training.
Yes. This hour has gone tremendously fast, Mario. I appreciate the fact that you're here and can provide us with all of this expertise and information. Thank you for your help, and of course, thanks for the Center for Connected Health Policy.
We're very grateful for this opportunity, and please consider us as a resource. We're publicly funded, and we're there to provide support in every way possible so that we can improve the quality of health for all Americans.
We're glad you had the opportunity and the time to spend with us today to follow along as we talked about telehealth and reimbursements. It's been a real pleasure bringing this information to you. Right now we're going to show you on the screen the contact information for both the Center for Connected Health Policy and for GlobalMed. And we'll do that as we conclude our program, coming to you from the GlobalMed headquarters in Scottsdale, Arizona. For GlobalMed, I'm Roger Downey. There were some questions that we just didn't have time to ask and find answers to. So we thought we'd keep Mario Gutierrez, the Executive Director for the Center for Connected Health Policy, over for just a few minutes to answer some of those, and then we'll put this on our video channels. So first of all, Mario, how do telehealth policies affect telerehab, and as far as Medicaid and Medicare?
Well, I think that, as I mentioned in our presentation, every state has their own guidelines related to what's reimbursed from their Medicaid program. So things like occupational therapy and physical therapy are allowable in many states. And so I think it's one in which you need to go to our website and see what is allowable. And also a number of private providers are now reimbursing for telehealth for occupational therapy and physical therapy and things of that nature. So
and it could be an
benefit.
expanding field, you just never know.
Well, the technology is such now that it's, you can do physical therapy in the home as well as in the hands of a physical therapist.
It's probably going to take some entrepreneurs to get involved with that and sort of sort through what they need to know and do for that. How do the existing and pending regulations impact audiology and speech pathology?
Again, another one of those areas that are, what this question really tells me is that any form of healthcare support has a potential of utilizing telehealth. So whether it's audiology, speech pathology, one of the great benefits of Storeandforward has been the use of teleophthalmology to be able to do retinopathy, as it's called, that can prevent blindness in diabetics. And so you can find in just about every aspect of anything other than requires manipulation, you can find a benefit in telehealth. And again, every state will have their own regulations and laws related to public reimbursement.
As we stated during the program, 50 states, 50 different recipes.
50 different recipes.
That's right. How do you evaluate the cost to operationalize telehealth across a large health system?
Well, I think that's a complicated question, can't be answered in a short time here, but some of the highlights that I would bring up is that a large health system has the benefit of the economies of scale of being able to utilize specialists in a much more efficient way if they have telehealth at their disposal. Instead of having 6 specialists, dermatologists or radiologists, or whatever the case may be, in each of the different parts of their system, even if it's in different states, you can use telehealth as a mechanism to increase the efficiency. Also, different kinds of providers. The way a system is organized needs to be organized in support of telehealth as opposed to overlaying telehealth onto a system that's broken.
Yeah, don't you get the sense that some hospital organizations are coming late to the game in the sense now we've put together this accountable care organization, now we need to know how to use these physicians we've hired?
Well, that's part of the problem as well, is lack of understanding. I think our biggest goal at the center, and I think nationally, is to encourage the most accurate, up-to-date information about what telehealth is and its benefits, and to try to dissuade some of the misconceptions that exist.
What should mental health practitioners know about informed consent when using telehealth? You know, obviously practitioners understand what informed consent is, but let's say somebody is watching this and doesn't know what that means. That means that the physician has explained both the risks and the benefits of a treatment or procedure to the patient, and then the patient has signed off on them, right?
Right. And the answer to that question is in 2 ways. One is whether it's mental health, whatever forms of services, you must comply with HIPAA regulations of informed consent right from the very beginning. Is there anything special about telehealth consultation? Again, it depends on the state. If a state requires a written consent, then whether it's telehealth for mental care or for any other form of care, you have to comply with that. Some states require verbal consent. That's kind of in a gray area. How do you document verbal consent? The important thing is that I think consumers should be educated about the benefits of telehealth and that it's not secondary care and that they're actually enhancing and creating a better environment for the care that's being provided, whether it's for physical care or mental health care.
Yeah, because sometimes the informed consent aspects in any state might include the fact, okay, these are the treatments and the procedure. Now we have to also have you sign an informed consent about telehealth,
Right.
because they somehow believe this is different in a way.
Right, right. Informed consent is usually, not usually, it's mostly used when it's an experimental procedure, when there could be a risk or a hazard to health, when it's not been approved by the FDA. Telehealth is not a procedure. It is a modality of delivering health care.
And how do we get that across to people? That is really a key issue here.
Absolutely is. And I think it's, one is the fact that to see it, to observe it, to be part of it, to look at the studies that have been done. There are a number of studies that have looked at consumer satisfaction. The fact that it literally saves lives, it improves care, it reduces costs. So I think as we learn more about it, we'll able to kind of neutralize some of these misconceptions that exist about telehealth, that it's going to just add all this new cost to the system and be a second-class form of care, which is just the opposite.
When there's mystery, there's often confusion and fear. So I think that's another aspect as far as the consumer is concerned. How does this affect me is going to always be the question until they actually do it. And then they're going to find that it's nothing more than just going to the doctor.
Well, it's more than that. It's what we find is in some of our interviews, people who live in rural areas or even in urban areas, underserved communities, and when they go to see their doc, and there is this great technology, and there's these specialists that are at the top of their field helping me, it makes them feel that much more special and have a greater image or impression of their system, of their clinic. It's not just, I've got this little rinky-dink clinic over here, and if I could go to Phoenix instead of, I'd get better care. Well, no, just the opposite.
This has been a pleasure to have you in studio and not only do this part of the video, but also the hour-long program that we just completed. Thank you for coming by, and this is, I think, beneficial information to not only providers, but to regular consumers who are concerned about the healthcare future in the United States.
Well, it's truly been my pleasure, and it's great partnering with you, and hope we can do it again.
Okay. Let's show again the contact location and information in which you can reach the Center for Connected Health Policy, and of course GlobalMed, which is where we are today in the GlobalMed production studio here in the headquarters at Scottsdale, Arizona. And again, for Mario Gutierrez, I'm Roger Downey. Thanks for joining us.